saw you there in your spring garden there. You know you gave it a chance and wanted to be a friend. Wanted to be a friend. Felt like a pleasant place of warmth and peaceful space. You know the words aren't really know, but I don't care. No.
Hello, everybody. Can you hear me? Yep. Okay. Hello, all. My name is Rajiv Krishnadas, and I'm a consultant psychiatrist in early intervention and psychosis in Glasgow. I'm also the clinical psychiatrist lead for the EIP program. Welcome to today's EIP Early Intervention Psychosis National Network event. The EIP program is part of the Improvement Hub of Healthcare Improvement Scotland. The program of work has been active since 2018, and as a national priority is currently funded by the Scottish Government until 2023. The first phase of this work resulted in a report published in March 2021, which recommended that all NHS boards should establish EIP services, which enable reliable delivery of evidence-based interventions and minimize the duration of untreated psychosis. The evidence is quite clear. Intervening early with the right set of approaches delivered in the right way will lead to significantly improved outcome for people. The ultimate aim of this work is to develop, design, and deliver EIP services across Scotland and improve outcomes for people with first episode psychosis. As part of our learning system, we are providing this opportunity to hear from Professor Rachel Upthegrove, who I will introduce in a moment. But first, I will pass to Andrew, who will go over the housekeeping for the session. Andrew.
Thank you, Rajiv. So, this session will be recorded, and by taking part, you consent to this. A recording of this session and resources covered will be made available following the session. Please use the Q&A function to submit your questions for the speaker. I'll show you how to do that now. The Q&A panel shows up when you click the icon on the top right-hand side of your screen that you can see here. Submit your questions using the text box shown. Submitted questions will show up in your My Questions tab. Once approved by the moderator, it will show up in the featured panel. Make sure to upvote your favourite questions. And I'll hand back over to Rajiv.
Thanks, Andrew, and thanks to the EIP national team and to the National Video Conferencing Services, who have been absolutely crucial in making this event possible. Now, I would like to welcome our speaker for the event, Rachel Upthegrove, Professor of Psychiatry and Youth Mental Health at the University of Birmingham and consultant psychiatrist in the Birmingham Early Intervention Services. She trained in medicine at the Royal Free Hospital, University of London, and completed psychiatry training in Birmingham. She completed her PhD at the University of Birmingham, investigating depression and suicidality in early stages of psychosis. Her recent research interest is the identification of underlying mechanisms and treatment options for comorbidity in early stages of schizophrenia. Recent projects include the investigation of inflammatory mechanisms and phenotypic profile of psychosis and the use of data science to develop stratification in heterogeneous early phases of developing mental ill health. Professor Upthegrove is going to speak for 45 to 50 minutes, and then we will have time at the end to put some of your questions to her. So please don't forget to post questions in the Q&A section and upvote those you would like answered. Over to Rachel.
Thank you very much for the kind invitation, Raj and Jeev, and the opportunity to come and speak. I hope everyone can see me and see my slides. A shout if you can't. Yes, so my name is Rachel Upthegrove. As Rajiv says, I'm a consultant psychiatrist primarily in the Birmingham Early Intervention Services, where I've worked for a number of years now, and Professor of Psychiatry and Youth Mental Health at the University of Birmingham. And I'm going to talk for a little bit of time now about some of the research that I and others have done around recovery, remission, and suicide prevention in early stages of psychosis. Just some disclosures to start off. To be fully transparent, I have received speaker fees from companies, but all of the research I conduct and I'm speaking about today is not industry funded, so funded by NIHR, MRC and other independent bodies. Just to give a brief outline and orientate you to the talk, I'm going to talk about early psychosis, and I know you've had Max, Max Bertrand come speak recently, so that a lot of the history of early intervention has been rehearsed very eloquently there. So I'm not going to go over too much about that. I'm going to focus on recovery and remission, suicidal behaviour, and particularly the idea about what we call comorbidities in early phases of psychosis, depression, and anxiety. I should probably just say as a caveat at the start that I'm a psychiatrist, and some of the talk content of the talk is going to be perhaps more weighted towards medication and medication management, but I'm a dyed-in-the-wool early interventionist, and I understand that that is only one part of a comprehensive package of care that services need to be offering and patients can choose to engage with. But getting the medication management right in early phases of psychosis is really important for remission and recovery and suicide prevention. So I'm going to focus a little bit more heavily on the medication rather than psychological therapies. But to start with giving a bit of context and where we come from and where I come from. So EIP in Birmingham has been around since 1995 when Max and Dermot McGovern set up the first services. And at the moment we work quite uniquely now within England within a youth mental health service. So our early intervention services are embedded within this and run from 16 to 35 and are not age inclusive, unlike most of the rest of England now. And my experience and some of the data I'm specifically showing around Birmingham is around the relatively unique demographic and population of Birmingham, which is a highly diverse, highly young population, and of course that brings different challenges compared to perhaps more rural and other areas. What I wanted to start off by talking just very briefly is about the clinical presentation in early stages of psychosis, and this is a graph that you've perhaps seen before. Where we see the onset of positive symptoms, so voices, delusional beliefs, paranoid ideation, gradually increasing as someone might move from an at-risk mental state to a fully formed first episode psychosis. And as Raji said, this challenge about reducing the duration of untreated psychosis is part of our raison d'etre, as it were, because we know that a longer DUP is related to poorer outcomes. And the critical period hypothesis is that really sort of robust care in this early stages can improve outcomes. The point of showing this slide is that actually what we have here is rather a one-dimensional understanding of what happens, and actually this gradual increase in positive symptoms belies what is actually really complex and dynamic development of mental ill health, and sometimes positive symptoms are only a epiphenomenon, or perhaps not even the most important phenomena in any one individual patient's presentation, and it's not a linear pathway for the majority of young people. I'll go into this in more detail at next stages in the talk. But just to emphasize this duration of untreated psychosis, this is from the onset of really frank positive symptoms of psychosis to the access and receipt of therapeutic care, medication and/or psychological therapies. And we know that DUP is a predictor of poor outcomes, but also that protracted journeys into care, add toxicity, trauma, and risk. And the idea about risk is something I'll come back to. So just to give a definition of DUP there for folk. And of course, in early intervention services, we aim to reduce DUP by promoting early detection, operating in an assertive outreach manner, going to see patients and people in need where they need to be seen, not waiting for someone to come to see us. Optimizing engagement, assessment and diagnosis by using this biopsychosocial approach. So not just about medication at all, and maximising recovery. And I think that the thing for me, and the point that I'm making, is addressing not just these positive symptoms, but comorbidity and identifying treatment resistance early. We also, obviously, getting folk engaged in treatment by that assertive outreach approach and assertive follow-up throughout the critical period. So some of the other principles, just to remind you that early intervention in psychosis is formulation based. So again, a biopsychosocial formulation based, guiding an individual patient's care plan. A couple of other things that are really key is this about embracing the diagnostic uncertainty. So we don't wait for clarification whether someone has a diagnosis of schizophrenia or bipolar disorder or schizoaffective disorder. We treat what we need to treat with the patient in front of us, and that watch and wait moves towards a treat and see. So make a diagnosis, but be prepared to revise that. Treat within guidelines, but be prepared to take a step back and reformulate. And that we embrace also the idea of substance misuse, childhood trauma, deprivation, and environmental stresses as making a diagnosis of psychosis more likely. So not excluding anybody from services because of particular comorbidities. But one of the things that I think that's really important to accept is that first episode psychosis and early intervention services are not schizophrenia services. So in a cohort of patients that would come through EI, any one of a number of different final outcomes, after a period of time can crystallize. So a number of patients that would come through EI might leave with no diagnosis of any mental health disorder at all, and that's a good outcome, of course. Some people might be on a pathway to having a diagnosis of schizophrenia. And good care can reduce the impact of that. But there's a number of different, diagnostic categories that can emerge from that early first episode psychosis phase. And we, at the moment, Rajiv and I can perhaps talk in the question and answer about prediction, but at the moment we have really no robust methods of predicting for an individual patient what pathway or what recovery outcome they will have, or what diagnostic category they will have at the end of time. So this is what we say when we have to embrace the heterogeneity and embrace the diagnostic uncertainty and work with what we have in early phases of psychosis. And this is relevant, particularly when we think about pharmacology and medication prescribing, because our guidelines are very much based, and our prescribing guidelines are very much based on trials that have been tested in patients with diagnosis of schizophrenia, rather than this early heterogeneous phase. I think the other thing to recognise is that in early intervention, outcomes are better than they are without EI, and I know Max and others have rehearsed that evidence. But we haven't fully addressed, everything. We haven't solved the difficulties just by EI, and it's what happens within early stages that we need to really refine and build our evidence on and make better and better. Because despite early intervention, outcomes are better, but they still aren't great. So from this review paper by Lally and BJ Psych a couple of years ago, we know that nearly 60% of FEP patients will meet remission criteria at 5 years, but fewer will meet recovery criteria. And I think we need to understand the difference between remission from symptoms and recovery, which is getting fully back to a functional level that somebody would previously had achieved. So fewer people will meet full recovery criteria. And having talked about the difficulty of diagnostic certainty in first episode psychosis, those patients who hit services already meeting diagnostic criteria for schizophrenia, only 30% will meet recovery criteria over time. And this is just some data from our National Eden study a few years ago, which just shows that we're quite good at, having this symptomatic recovery in the first 12 months of EI. So patients generally are getting better, and functioning. So this is the global assessment of functioning. Functioning's improving. But if we look at the actual level, so a GAF of 60 is still really quite impaired, and I suppose the point of the slide is saying there's still an awful lot that we need to do to really target recovery and recovery in its fullest sense for patients. So I wanted to talk a little bit about prescribing, because it is an important part of EI care to get right, and to make sure that it's nuanced and done properly. So this is a paper we published a couple of years ago, which just showed the sort of general prescribing in UK early intervention services, again taken from the National Eden study. So the majority of patients are prescribed, a single antipsychotic, but certainly not everybody is on antipsychotic medication. Antidepressants just prescribed for about 20%, and smaller numbers of mood stabilizers. And the majority of people are prescribed second generation antipsychotics, so olanzapine and risperidone. So again, if we have time in the Q&A, I can talk a little bit about the metabolically active and metabolically inactive medications and treatment choice in first episode psychosis. But I think the point of this slide is really that we aren't using the full arsenal of medications, and that particularly olanzapine and metabolically active medications can add to the illness burden in early phases. We need to be doing that with informed patient choice, and really keeping an eye on our level of prescribing in early stages, because we know that once someone has reached a level of symptomatic control, that actually dose reduction, as part of EI care, is really important, because this is a time when we have more monitoring, we have more lower case numbers for care coordinators, we perhaps have more medic input, and we really need to be getting a handle on someone's medication regime. So treating early and then getting dose reduction down early, to a minimum effective dose that's needed to prevent relapse. And this is just obviously the Wonderlink study from a number of years ago, which showed that actually minimum and low doses of medication are more helpful, in maintenance phases in schizophrenia. So this is what we should be aiming for in early psychosis services, so the lowest effective dose of medication. And just to talk a little bit more about that dose reduction, which is important. Without going into too much of the pharmacology, we know that we can make quite significant dose reductions from higher doses. So you can go reduce from, say, 8 milligrams down to 6 milligrams to 2 milligrams of risperidone relatively quickly. And then once you get down to the tiniest levels of medication, dose reductions need to be done with more care. And this is all to do with how medications affect the D2 dopamine receptor occupancy. So we can make really quite good steps to reduce doses of medication down so patients aren't experiencing side effects relatively quickly, and then have a nuanced conversation with the patient while they're within EI care about, is this the time to try a medication-free period, making sure that someone has a robust safety monitoring around them and has good early warning signs work and relapse prevention work completed. But this is part and parcel of what's needed within EI care. So, symptomatic control and early and active medication tapering down to the lowest possible dose, and then, if appropriate, trials off medication while someone's with EI care. On the other hand, we, as I said before, we know that up to 30% of patients with first episode schizophrenia will have treatment resistance, and this was a really sort of recent meta-analysis, again in BJ Psych by Siskin et al., which showed again 24% of patients with first episode schizophrenia meeting treatment resistance at first episode, and are we doing enough to spot that early and to target effective interventions early? So again, understanding that this is something that we need to be very proactive in our management of, because it's really important. Again, previous work has shown that up to 1 in 5 patients may be eligible for clozapine in early intervention services, but even within robust EI services, there's delays in getting patients onto clozapine. But those patients who are identified as treatment resistant in EI and commenced on clozapine, up to 78 will actually achieve that remission. So again, our studies on clozapine have been done in patients with treatment-resistant schizophrenia from much more chronic stages of illness, and we've yet to do this to do the trials of clozapine in early stages of treatment resistance. There's a study called CLEAR that James McCabe is leading on, which is going to be addressing this very question opening soon. But from our sort of observational and other evidence, we know that clozapine, if it's used in this phase, has a significant impact. So we also need to be identifying patients who have treatment resistance early and having conversations with them about how to start clozapine. And again, looking at our national Eden data in the UK, we're not doing this well enough at all in England. So only 1.9% of patients were prescribed clozapine during this critical period, and patients were tried on 1, 2, 3, 4, or even 5 different antipsychotics before being offered clozapine. And I think that that is. It's, as I said before, EI is always a work in progress, but that's something that's really, really important to understand when you're developing services, that EI services which are community based, have to be able to have the staffing to start patients on clozapine in the community, because the last thing we want to do is admit someone to hospital, if that's not necessary, just to start someone on clozapine. So it is something we can do in Birmingham, but it takes an awful lot of staff resource to be able to do this safely in the community. But I think, personally, I think that has to be part of the standard offer of an EI service, is the ability to do that and have the staffing able to start patients on clozapine while they're with us. So I wanted to talk move on to talk a little bit more about recovery and comorbidity, and move a little bit away from clozapine and pharmacology for a little while. And because it's not just about remission of positive symptoms, it's not just about medication, and what we know is that first episode psychosis comes with a whole bag of not just heterogeneity but comorbidities. So work that we've done here with Max and Maria Mikhail and others have shown that up to 40% of patients will experience post-traumatic stress disorder after first episode psychosis, and this is related to the experience of psychosis, threat from persecutors and voices, and protracted and coercive pathways into care, and that social anxiety and shame are really important and common after first episode psychosis. So just that understanding of how I might get back on my feet, and understanding that the level of anxiety in a patient population is really important. Check here. Yes, and thinking perhaps even earlier on, so it's not just about the first episode psychosis experience, it's about what happens during the at-risk mental state as well. So very, very high levels of affective comorbidity, and this is where I start getting uncomfortable with calling it a comorbidity, because actually it's so prevalent, and for a lot of people, particularly in the early phases of illness, this is the thing that drives people to try and get care. Low mood, depression, and 50% with anxiety disorders, and these are related to functional outcome in at-risk mental state, irrespective of transition, so irrespective of whether someone develops psychosis or not. And we know that the long-term outcomes after in the at-risk mental state are not great, again, despite whether someone would make transition or not. So that group of people who don't make transition still have very, very high levels of access 1 disorders and will be in mental health services. This is part and parcel of the argument for armed services that, again, we can perhaps go into in questions if we have time. But coming back to first episode psychosis and comorbidity, the work that I've been sort of focused on in sort of recent years is understanding the prevalence and the importance of depression. So this was just a longitudinal study of first episode psychosis patients who came through the Birmingham service, and I think the thing to note here is the line at the bottom. So the minority of people will come through a first episode psychosis without experiencing a clinically significant depressive episode. So here we charted not depressive symptoms, but major depressive episode. And it's only the minority of people who won't experience depression. And since then, we've tried to pull together evidence about the impact of that depression in first episode, and we know it's related to poorer functioning at the time, but it's also related to poorer functional recovery for many years afterwards. So follow up, as long as studies have been done, so that impact of depression on functional recovery is there, and it's long lasting. And also, I'm going to come on to talk about suicidal behaviour shortly, but also that impact of depression in first episode psychosis also conveys risk for suicidal behaviour for many years hence. So affective dysfunction and depression in particular are important in and of themselves. One of the bits of research we did a long time ago was just trying to understand where this depression comes from and how we might understand this in relation to the experience of psychosis and positive symptoms. So this was just a little piece of research which showed that actually the depression was associated with both self-stigma and shame, feelings of loss and lack of control over one's illness. So it's not just related to insight and awareness of illness, but what appraisals come with that increased insight. And so as someone is recovering from psychosis and becomes aware of their experiences, this is the time to really look out for this. And we've also done some pieces of qualitative research to put some meat on the bones of that, and the impact of first episode psychosis and depression, on recovery, social status and position, and really just understanding the full impact. So this is just some quotes from this qualitative piece of work that we did a number of years ago, showing the impact on social position, social confidence and social status. And of course, there's the role of childhood adversity. So I'm not going to rehearse the whole childhood trauma and psychosis literature, because that would be a talk in of itself. But to know that the things that might lead someone to develop psychosis will also lead them to, be at risk of developing, post-traumatic stress disorder, cognitive schemas that lead to depression and affective dysfunction, and that these things occur together. So it's not just that trauma leads to psychosis. Trauma leads to affective dysfunction and psychosis, and this is why we have to be so aware of trauma within early intervention services, because of the effect on comorbidities and outcomes. So a few years ago, we pulled together some of this literature, just trying to understand how we might conceptualize depression in schizophrenia and first episode psychosis. So this is sort of like 3 ways of trying to understand this. Whether depression is part of the psychological reaction to the diagnosis itself, as I've rehearsed very briefly before. Whether it is, as I've just said, that common things happen together commonly in childhood adversity will lead to both psychosis and depression. And then more recently, I've been interested to try and understand whether actually depression is intrinsic to psychosis itself, both at a symptom and a biological level. So I'm just going to whiz through a couple of papers on that tries to unpick this. One study that I'll talk about is related to the Pronia study. So I thought I'd just talk through what Pronia is. So Pronia is a longitudinal observational cohort study looking at recent onset psychosis, recent onset depression, and clinical high risk, which is the same as at-risk mental state, from 8 European countries, including Birmingham, with really quite significant both clinical, neurocognitive, and brain imaging and blood-based biomarker battery over the course of 18 months, with a total sample size of nearly 2,000. So a lot of different papers are coming out, and insights are coming out of Pronia. I was interested within Pronia about understanding this comorbidity of depression. And in this paper a couple of years ago, what we were looking at is to really see whether we could identify an effective subgroup of patients with first episode psychosis, and whether this would allow us to identify, who to target treatments to. And so we looked at patients with recent onset psychosis and comorbid depression, and we used machine learning algorithms to try and classify patients to see whether there was a separable subgroup based on both their symptom profile, but also so that their brain profile, so using structural MRI scans. And just to give you the headline in the nutshell is that basically we couldn't identify subgroups of patients with psychosis who had and didn't have an effective profile. So there was no distinction in the symptomatic profile between patients with depression with and without psychosis, and there was no distinction on grey matter volume between patients who had psychosis with and without depression. Excuse me. So this idea of affect within first episode psychosis is not a separable depressed subgroup, which speaks to whether there is an effective and a non-effective pathway into psychosis. So depression is pervasive, it's not distinguishable. Those patients who have high levels of depressive symptoms actually had worse grey matter volume loss when we looked at a different type of analysis down here, but actually that's not generated by an easily separable subgroup. And then more recently, a very bright PhD student of mine, Paris Lewis's, has been using more robust semi-supervised machine learning approaches to see whether we could disentangle this idea about heterogeneity in early phases of mental disorders. And using a completely transdiagnostic approach within the Pronia consortium, so patients with depression and psychosis and healthy controls, we're able to identify patients who had a more impaired clinical presentation, more affective dysfunction, more motivational difficulties, reduced grey matter volume loss, and cognitive dysfunction. But this cluster was made up of patients with psychosis, and patients with depression without psychosis. So actually, is there an even more sort of transdiagnostic way of understanding at a symptom level things that we're picking up in terms of comorbidity? And if we actually take a fully transdiagnostic approach, we might be able to identify new treatment targets. So again, that's slightly, it's a nice new paper, so I wanted to show that to us, but slightly off course from my early intervention. But I wanted to say that basically there's evidence coming to say that depression might be a potentially novel treatment target in early intervention. I say novel because, of course, depression it has been and is a really key key feature of CBTP, despite the fact that CBT is the trials of CBT have primarily been focused on the effectiveness of this, on positive symptoms or transition from high-risk status to first episode psychosis, but that the evidence suggests that actually depression, in CBT trials is a good target of therapy. And actually, when I speak to my psychology colleagues, with a formulation-driven sort of model of care, you're working on what patients are presenting with, and often it is around that stigma, that shame, that sort of loss of role that is the cornerstone of therapy. And of course, it's not just about CBT. So obviously, Andrew Gumley's work, and in Scotland has led the ACT therapy, and particularly this may be something that might be acceptable and an important intervention for depression in and after first episode psychosis. But coming back to what I know more about, and that's about pharmacological treatment. So we know that antidepressants generally work when we're treating a depressive episode in schizophrenia, and this is just a meta-analysis that demonstrates that, particularly focusing on SSRIs. And despite concerns about co-prescribing, and this is what I think I meant when I talked about our really sort of nuanced and refined prescribing in early intervention services, because we have to keep an eye on that antipsychotic dose, but we also have to treat comorbidities. The combined prescribing of antipsychotics with an antidepressant is relatively safe, particularly when that's done in a highly monitored way. This is just a slide from Tin Ho, and I always show which is a population level that those patients who are co-prescribed an antidepressant and an antipsychotic actually have an overall reduction total mortality compared to those who are prescribed an antipsychotic alone, and particularly those who aren't prescribed an antipsychotic. So we can have really sort of nuanced prescribing in early phases of psychosis, which has a significant impact on total mortality. And I'll come back to the reduction on suicide shortly. But just to give you the sort of heads up, this idea about antidepressant prescribing in first episode psychosis is something that we're also addressing here in Birmingham, a part of Birmingham, most of the northwest, with centres up to Cumbria and Wales, where we're trying to understand whether co-prescribing an antidepressant with antipsychotic will actually prevent depression in the first place. So rather than waiting for depression to develop, can we co-prescribe early enough to help prevent depression, and would that improve outcomes? So this is a relatively straightforward, multi-centre, randomised, double-blind, placebo-controlled trial that we're just setting up with a really large recruitment target, recruiting from EI services across England and Wales. Happy to talk to any Scottish services that might want to be involved. And we're basically looking at the number of new episodes of depression over a 6-month intervention phase, but also a whole host of really important secondary outcome measures, because the idea about preventing depression in first episode of psychosis is to improve recovery and prevent these other things happening. So sertraline 50 milligrams versus placebo, in addition to usual care, and as I said, we're recruiting all over England and Wales, and happy to talk to anyone that might be interested in setting up a Scottish arm. So just to kind of summarise where we are at the moment. So antipsychotic medication alone may be insufficient to reach remission and recovery, and I mean that within prescribing. So of course, psychological and social interventions are equally important. Clozapine isn't used enough or early enough in EI services, and we need to be able to spot and address treatment resistance adequately. Recovery is also related to other things like anxiety and depression and these comorbidities. Depression is pervasive, not a distinguishable subgroup, but it may represent a novel treatment target, and certainly something that we shouldn't miss. So moving on to suicide prevention and suicidality in first episode psychosis. And firstly, I'll say everything I've said so far around depression, of course, is relevant for suicidal behaviour and suicidal thinking because of the risk that brings. But just to give the context and to rehearse some previous literature, psychosis in and of itself, is a risk for suicidal behaviour and completed suicide. And one of the main things that we can do in EI services is make an impact on that. So this work from Ian Kelleher, a number of years ago showed that the experience of psychotic experiences at a population level is a risk for suicidal behaviour over and above any risk that has of being a hallmark of mental health disorders. So psychotic experiences themselves have risk for suicidal behaviour. So that's really important to note. That in our clinical high risk or at risk mental state that there are high levels of suicidal behaviour and suicidality. So 24% of patients would experience suicidal thoughts or behaviours, and that positive symptoms are really important and related again to that suicidal behaviour. So work from Alison Young here and meta-analysis from Paolo Fusopoli showing that. And as psychosis develops, that risk develops. So as soon as we start hitting first episode psychosis, incidence of suicidal ideas, plans and behaviours increases even further. So in this longitudinal study that we did, we found up to 56% of patients will have suicidal ideation or plans, and 33% would have a history of suicidal behaviour, so actual acts of incompleted suicide. And that was related to the affective dysfunction and depression that I'd previously just rehearsed. The duration of untreated psychosis and the first weeks of treatment is the highest period of risk. So in this study, we found that actually overdose was the most common method for incompleted suicide, and that often patients were taking an overdose on their prescribed medication. So the scenario may well be seeing the home treatment team or seeing an outpatient being given the first prescription for risperidone without a safety net around them, being given the diagnosis, and in the context of psychosis, access to ready means, so taking an overdose of risperidone was really common, but also other very significant attempts, so attempted hanging, jumping from a height. So in the context of first episode psychosis, suicidal behaviour is very important and unfortunately all too common. In established psychosis, so this is a paper from Rena Dutter back in 2010, which I think is really important for everyone to know and to recognise. So using big numbers of a longitudinal catchment population sample followed up for 11 years. Rates of completed suicide were highest in the first year after presentation. So within that duration untreated and early phases of treatment for psychosis. But then risk persists late, and so the risk persists for up to 5.6 years. So there's a peak and then a long tail of risk for completed suicide. But, and so on a positive note, early intervention services do seem to make an impact on suicidal behaviour, and that's probably related to their impact on DUP. So again, looking at the Scandinavian studies, which showed that early intervention services have an impact on the duration of untreated psychosis. Communities that weren't served by early intervention had higher rates of suicidal behaviour. So we can see that there is an impact of EI on risk. And more recently, this paper from the Hong Kong group, Chan et al., published in JAMA, really showed that impact of early intervention, again, not just on the acute risk, but on the longer term risk. So in their cluster randomised controlled trial of early intervention services, those patients who received standard care had a higher rate of of mortality, so survival was better in the patients who had received early intervention. And that wasn't just during the early intervention phase, but that again, had a longer lasting effect. Interesting. There was a nuanced difference in terms of the risks for completed suicide in the early years versus the later years. And in the early years, and this reflects some work that we've done in the past as well, that if someone has had a previous attempt, that is a very strong risk factor for future attempts and completed suicide in early stages. Later on, it's more to do with relapse, adherence, and occupational impairment. So when we think about duration of untreated psychosis, so when we think about suicidal behaviour, duration of untreated psychosis is key. And that's for a number of reasons. We think about what happens during the DEP phase, not just untreated positive symptoms, command hallucinations, etc., but the amount of loss that occurs. So loss of role, loss of support, loss of friendship groups, these things that we know are protective. The development of treatment resistance, and the embedding of positive symptoms, so enmeshed delusional beliefs. The development of hopelessness, because everything that I've just rehearsed in terms of loss of role, support, friendship groups, harder pathways to recovery lead to hopelessness, and then the risk of untreated psychosis itself, so for command hallucinations, etc. So acts of self-harm becoming repetitive acts of self-harm. So I tried to put this all out into a bit of a schema, which seems to tweak each time I put it together. But we have, childhood trauma, social social deprivation, leading to both self-criticism, perhaps poor problem solving, and also psychosis itself, leading to affective dysfunction, as I've previously rehearsed. That engagement with powerful voices, subordination to persecutors, our own health services response, so coercive, pathways to care, use of Mental Health Act, which is of course necessary in some cases, but is traumatizing, leading to positions and feelings of entrapment and demoralization, hopelessness, and suicidal intent. So the whole point of early intervention services, particularly in relation to suicidality, is to be recovery focused, to be hopeful, to be robust in terms of being able to address the idea of recovery and maintaining recovery through these early years to reduce that suicidal behaviour. Coming back to what I was saying, that this idea about significantly reducing completed suicide by addressing and understanding comorbidities, and particularly depression and affective dysfunction, both within pharmacological and non-pharmacological means, seems important. And coming back to pharmacology to end on this, we know that clozapine in and of itself reduces completed suicide, the risk of completed suicide. So being able to understand and address treatment resistance early and get people on clozapine to improve their symptom profile and reduce their suicide risk is important. And again, what we can see here is that clozapine, in terms of a meta-analysis, really does have an effect on completed suicide. And those patients who are continually treated with clozapine have lower completed suicide rates over a longer period of time. So really, really robust evidence of that. So, in summary, it's not just about duration of untreated psychosis, it's about untreated and unresolved psychosis is key, because, as I've said before, that this is around the level of loss that happens when patients and people are unwell with psychosis, the loss of role, support, friendship groups, and things that happens in this critical period. That the embedding and the unidentification and the lack of targeting of treatment leading to treatment resistance, embedding of positive symptoms and hopelessness. So this is why, as I said, that services really need to be recovery focused, remission focused, and able to manage really a very complex phase of early psychosis in a robust manner, so that we can address all of these things within a fully sort of biopsychosocial approach. And that for suicide prevention, effective early intervention services are important. Reducing duration of untreated psychosis is key. Targeting comorbidity and I'm repeating myself here, but having services that work within the idea of hope and recovery and work with patients to that goal are absolutely essential. So in summary, the early stages of mental health disorders are really heterogeneous, and that gives us as clinicians challenges to make sure that we are really on top of presentations and treatment, that are focused on positive symptoms and a hierarchical approach. You know, someone has schizophrenia, this is what I do. Someone has bipolar disorder, this is what I do, is not sufficient in early stages of the disorder to reach recovery and remission criteria. Active medication management is a really important part of a multidisciplinary team. It's not the only part, but it is an important part to get right, because if we get that wrong, it has really significant impacts. Recovery is also related to anxiety and depression. Depression is pervasive in early psychosis, and it's not related to a distinguishable subgroup. Prevention of depression may improve outcomes and reduce suicidal behaviour. We're addressing that with the ADEPT trial. An EI and recovery focus is essential for suicide prevention. So if I hope I've got my timings right, Rajiv, that I've finished dead on time, maybe a little bit early, and we should have some time for questions.
Perfect. That was perfect timing, Rachel. Thanks a lot for that. And I'll go straight into the questions, because I think we have around half an hour for the questions, and we have quite a bit of interest as well. I have in the question and answer section, I've ordered it according to the most liked questions. I don't know if you have access to that as well, Rachel. So there is, I'll start off with I think we'll probably start off with the most liked questions, and that's from Professor Pelosi. Tony asked Professor Upthegrove, given the figures from your slide showing that only a minority of patients meet recovery criteria after 5 years or so, do you have recommendations about the transfer of care after patients finish with early intervention for psychosis teams? I'm very concerned that early intervention teams in parts of England are discharging the majority of their patients with psychotic illnesses to primary care. In Oxfordshire, this is as many as 83% being discharged to primary care. I'm very concerned that this is going to happen in Scotland. Do you have any recommendations about this? And I think there's a sentence which is partly there, but I think the question's there. So the recovery rates are not very good, but most people are being discharged to primary care. How do we explain this phenomena?
Well, I think that I know the Oxford paper that Tony that you're speaking about there, and I have some sympathy and agree with your points that actually the discharge pathway after early intervention again needs to be an individual patient basis, and the ongoing services after EI need to be able to manage those. So I think when we were setting up services, is it EI or CMHT? I think that we've moved on from that in England now, and it's EI, and then what happens after EI, because we have this really key piece of work to do within early intervention, and then we need services that are able to maintain the gains that we have hard fought won. And in Birmingham, I can tell you, without any hesitation that 83% of patients are not discharged to primary care. That there is a need, of course, for really well-resourced mental health services for every age, and it should not be that somebody has robust care for first episode psychosis and then doesn't have robust care if they have treatment resistant schizophrenia. And if we were we can think about whether the cancer analogy is a right one or not to make for mental health, but you wouldn't say that actually we're going to really give really good early phase treatment for patients with breast cancer and do lots of prevention, and then not have any cancer services for patients who have stage 3 or 4. So we need both. But we do have an awful lot to do within the first years of psychosis, and EI is part and parcel of that. So it depends on the level of deprivation. It depends on the diversity of your population. What happens in inner city Birmingham and inner city Manchester and inner city Glasgow is probably very different to what happens in Oxfordshire. And because of the comorbidities that we would see, needing much more sort of robust packages of care. So I hope that answers the question.
Sorry, can I add on to that question, Rachel? Sorry, I'm hijacking Tony's question there. Is it possible that it's because of the heterogeneous nature of first episode psychosis? And you mentioned that a lot of people they don't necessarily go on to develop one particular, it's not a first episode schizophrenia service. It's a heterogeneous group where a lot of people just go on to have no diagnosis at all. So for example, if I take on people with at-risk mental states, the conversion rates are quite low, if I'm right. And I don't know if Oxford group actually have those people as well involved, or I don't know if it's too heterogeneous where a lot of people then don't go on to develop a schizophrenia kind of illness, or a bipolar disorder. It may be just depression or no diagnosis at all, where they're kind of go back to primary care.
Yeah, no, I think it's right. Interesting if you think about the level of morbidity in different parts of the country and different populations. So if you look at James Kirkbride's recent work, and particularly his Synaptic tool, which maps the predicted incidence rates of first episode psychosis, an area like Birmingham would have huge numbers, compared to sort of more rural areas, and therefore the tension, if services aren't sufficiently resourced, is that your first episode psychosis service becomes a first episode schizophrenia service, because you have only capacity to take on so many patients and still deliver good care. So I think that where we're trying to move to now is trying to understand where that morbidity within the heterogeneity comes, and it's not just about the positive symptoms of psychosis, it's about everything else that comes with that. And of course, in an inner city area, you're more likely to have a higher load of psychosis, and therefore a higher load of schizophrenia within that heterogeneous first group. So a higher percentage of people who would need ongoing care.
Okay, I will. Thanks, Rachel. I'll go on to the next question, which is, I think there are a few questions based on clozapine. So interesting data and statistics around clozapine being offered. Any thoughts around why this isn't being used more routinely, other than the challenges of community prescribing?
Well, I think it's probably two things. I think the challenges of community prescribing are there and really really impactful. Particularly in England at the moment, we have really hard access to inpatient care. So a planned admission for clozapine in some areas of the country are just completely impossible. So if you don't have a home treatment team or an EI team that's able to do that community onset, it becomes something that you can't offer. So I think that there is a logistic need. I also think there's something about how the mindset of early intervention services, and how we went about things, of this idea about offering hope and offering recovery, and saying that this is the first episode. It doesn't have to be, it should be the last episode, that we're focusing on recovery, and an understanding of the medicines management within EI services, meaning that perhaps we didn't want to identify patients as treatment-resistant schizophrenia from the first episode. And I mentioned the evidence on clozapine. When we complete the CLEAR study, we'll know whether clozapine is effective in children and young people. At the moment, the clozapine studies are generally done in patients with established or chronic schizophrenia. Some meta-analysis, that has been done has shown that actually if you start clozapine earlier, it is more effective, as I said. But I think it's a tension between the practicality of doing that, which would take up nursing time away from other things, and actually what we need, as I said, is services that can do both. That can do the recovery, that can do the relapse prevention, that can do the CBT, that can do the family interventions, and can offer clozapine in the community, because these are all evidence-based interventions.
Thanks, Rachel. There's another question from Tony again. In regards to the other questions from audience members about clozapine, I'm concerned that, so I think there are other questions about clozapine. I'm concerned that clozapine is being started by teams that are only involved in patients' care for 2 or 3 years. The decision to start clozapine is a decision about the ensuing decades, not the next few years. Do you always involve the catchment area as the consultant psychiatrist and the CMHT in the decision to start clozapine?
Well, I think that it is a long-term decision, and I think that it's patient-led. So the patient should have the choice of starting clozapine, and it depends on where somebody might be within their EI team time. So if we've identified treatment resistance early enough, that should actually be within the first year, and then where their discharge destination, in terms of where they're going to live and how that what catchment area team they would be going to, wouldn't be part of the conversation. I think that would be too early. But in terms of having really robust conversations with colleagues as we're planning discharge from EI is something that we should and do. So it should be patient led, and it should be led by evidence, and starting clozapine in treatment resistance is something that we should be doing, not just for the treatment resistance, but also for the suicide prevention, as I think I rehearsed. Yeah.
Okay, I shall go to the next question. Is there a specific specialized suicide risk assessment that is used specifically within your early intervention service? I'm thinking Birmingham.
So formulation driven, but we don't use a specific suicide assessment tool or risk algorithm. I think, Raj, maybe we could talk about the risks of prediction if we have time. But I think it is something that has to be formulation driven, and understanding every single aspect of that person's presentation and care. The only thing I would say is that, of course, the most robust predictor of future suicide attempts is a previous suicide attempt. So we do make sure that we absolutely have the information we need in terms of our risk assessment, but we don't use a suicide prediction tool.
Okay. The next question, which has the maximum order. Do we feel that CBTP and psychological therapies are routinely available for people with psychosis or first episode psychosis? Not sure that this is considered as an early treatment intervention in Scotland. Significant waiting list for psychological therapies in mental health services currently.
So for me, the psychological therapies, are part and parcel of good care for patients with severe mental illness, and should be offered really crucially in the early phases, because, as I've rehearsed, the level of of impact of first episode. So yeah, I think that is. I think that maybe the nuance is that that doesn't necessarily have to be by a clinical psychologist. So CBT trained nursing staff, are really so valuable members of the team, and the nursing sort of specialty, I think, is something that should be championed, and just the role of the care coordinator, is so crucial in EI services, that we have to make sure that they have the right training, support, and time to do everything that can be delivered by nursing staff.
I mean, if I can kind of answer part of the questions about Scotland itself, I think within the early intervention psychosis and service in Glasgow, everybody's offered CBT, psychological therapies, and BFT. Of course, again, like Rachel said, it very much depends on the number of staff we have on ground as well. So that's absolutely crucial that we have enough staff to kind of deliver that. And I think that can be delivered. My thought is that can be delivered only within a first episode psychosis service, an early intervention psychosis service, given that we have fairly good staff to patient ratio.
Yeah.
So
yeah, I think.
Go on. Sorry.
It is about the staff, and getting staffing levels right is really important. But it's not just about the staff. And so well, if we funded all mental health services, as they should be, would we need early intervention? It's about that coherent group with a common aim, and common understanding, and common really sort of expertise. So if it's been something that you're entirely focused on, whether it be the clozapine, initiation or conversations with patients about clozapine, or family intervention, or CBT, or recovery, that really sort of tight MDT team working for a common goal, and surrounding the patient with all of the support that might be needed, again in the early years, I think is important. It's about specialist services, and again, in other branches of medicine, we may not be having such an argument as whether we needed specialist services or not, for breast cancer or other disorders.
So. Some of the local authority areas in Scotland with high suicide rates have rural or remote populations. Are there studies or recommendations that look at how to bring the benefits of EI to these services, these areas that are too small to support a full EI service?
Yeah. So there is, and I would recommend, if you're thinking about that, it might be an idea to start talking to the Irish burgeoning early intervention psychosis network. So I was speaking with Mary Cannon and Colin Healy just a few weeks ago. So they're developing their early intervention service, in rural Southern Ireland, which is very different to in a city, and so whether you have enough patients for a standalone service, or whether you develop a more hub and spoke, is a conversation to have around the demographics. But generally, if you have sufficient population, this kind of standalone EI service has a better outcome than a hub and spoke model, and so that's something that we reviewed the literature when we were thinking about our youth mental health services. But there are nuances when we're dealing with really sort of small populations in large geographical areas, of course.
Thank you. The next question is by Almut Maria Schmidt. I hope I'm pronouncing that properly. You once mentioned promising study results from Scandinavia. I was wondering, in regard to your notion that yet more may be done to help clients effectively and achieve higher rates of remission and recovery, whether adopting more closely approaches from the Scandinavian open dialogue model would be a valuable way forward. open dialogue seems to consistently achieve high levels of recovery, and that with a usually much lower amount or shorter duration of antipsychotic medication. The side effects of which I may add have not been mentioned in your talk, although there is a wealth of evidence suggesting that medication itself may be involved in maintaining symptoms, especially negative symptoms. I think that might reflect, the one drink study as well, the dose reduction, etc., etc. So thank you. Sorry.
No. Yeah, I think that the open dialogue work is really important. As I said before, medication is only one part of robust care. I think anything that can address the kind of the social anxiety, the need for peer support, the need for recovery. Personally, I'm all for it, and I think that we should support. We're sort of slightly governed by NICE, certainly in England, and our early intervention services are driven by sort of NICE guidelines. But I think open dialogue is a really important aspect of potential care that can improve recovery. And so when I'm talking about recovery focused services, I think anything that we can do that would improve recovery, I think should be considered. Just on the medication side effects, I didn't want the talk to be to be a pharmacological talk, but I absolutely am with you there. That antipsychotic medication can have significant side effects, and we need to be managing that proactively. And so within EI services, I think particularly in England, where still the majority of patients might be started on their first antipsychotic medication by a home treatment team in crisis, that conversation about what medication and the longer term effects it may not be possible to have, but that's a conversation that we should be having within EI services straight away. And so dose switching, so medication switching to something that's less metabolically active, dose reduction very, very proactively is something that we should be actively managing, and then talking to people about when is the best time to have that trial off medication, if that's something that they want to do and is safe to do. So we know that patients with schizophrenia die 20 years younger than the general population, and a lot of that is to do with metabolic dysfunction and metabolic risk, and that is in part triggered by metabolically active antipsychotic medication. It's not entirely to do with medication. So some of the work by Ben Perry and others recently has shown that actually, potentially an immune dysfunction, an inflammatory pathway might predispose somebody to both metabolic dysfunction, so diabetes and psychosis, and this might be relevant for a subgroup of patients. But these are the patients who should not be prescribed olanzapine, for example. At the moment, we don't really have any way of knowing who's going to develop metabolic dysfunction, to aid that choice. We can't predict it because, again, Rajiv and I can talk about prediction models. Our prediction models for that aren't good enough at the moment for clinical practice. But that's why we need to be monitoring and talking and switching and reducing in a proactive way. So when we think about the staffing levels to do that, we need to have staffing levels for psychiatrists or non-medical prescribers, or people who can have that conversation about medication enough to be seeing patients, every couple of weeks, weekly during those first few months of first episode psychosis, to have these conversations, not start someone on a medication, review in 3 months. It's too late. We have to be able to see patients often enough to make those really sort of thought through decisions and monitoring.
Thanks, Rachel. Next question is, right, this is probably directed to myself. I was just reading it just now, but also I will. It's anonymous. It's from someone anonymous, so I suspect somebody is working with me. I work in a general adult CMHT, and we sometimes struggle to get our EIP colleagues to take patients, as we are told that their psychotic experience are not a primary psychotic illness and are driven by mood or anxiety and not suitable for their service. On occasions, we have been told that the stigma of them being attached to the EIP service is unhelpful, and it is better for a more generic approach. Listening to you today, it would seem this likely to lead to patients who probably do require the EIP approach missing out, particularly given our difficulties getting timely psychology. Whilst I understand that EIP services are trying to gatekeep, I fear this is the problem of a specialist service who are able to say no to cases, knowing that CMHTs will have to pick up. I suspect that's probably a local issue, Rachel, rather than, I mean, so this, I'll probably the concept of a primary psychotic illness versus a psychosis secondary. I suspect what my own thing is that where we can, where it's a very clear substance-induced psychosis, or whether where you clearly stop the substance use and the psychosis goes away, not necessarily with treatment with antipsychotic, or where people who do have an emotional and stable personality disorder, who have these brief episodes of psychosis which are self-limiting, or an acute and transient psychotic illness where the psychosis may just go away completely. That is, I suppose that would be a primary psychotic illness. But even say a primary depression with psychotic illness. I mean, you said that early on, the diagnostic uncertainty, as a heterogeneous nature of this condition, we are not exactly sure where it is. But also that's one of the things. And the second thing is an EIP service, is an outreach service like EIP appropriate for all kinds of patients? Are there subgroups of people who it's not appropriate? And the thirdly, the funding. Not having enough funding, we kind of tend to close down our our diagnostic categories, basically. So from a first episode of psychosis, it becomes a first episode schizophrenia service, where that's a risk of it happening. So I'm not kind of trying to justify there. I suspect I'd rather kind of have a talk about this within our service here itself. But your thoughts about that, Rachel?
Yeah, so I think that these are conversations that we've had over the years, for many years, and I think the key is to try and make sure that our intellectual thinking isn't distracted by service level pressures. And so if we're saying that actually it's impossible to make a distinction between what's primary psychotic illness and a primary affective illness, in early stages. If you say that actually the illness heterogeneity is so large within those first episode, that actually if you have a sufficient level of psychotic symptoms which impact on functioning and distress, that somebody should come to an EI services. That's where it should be, and services should be appropriately able to to take on those boards. I think it's really not dangerous, but it goes against the ethos of EI to say something is a primary affective disorder, because hopefully I've convinced you here that there is no such thing as a primary affective or non-affective psychosis in early intervention phases. That becomes clearer, as the pathway develops. And then when we think about substance misuse, well, my stance is always somebody is smoking cannabis, they're far more likely to develop psychosis and schizophrenia than less likely. So shouldn't we be seeing them as well? And you can have this argument with yourself. Someone has childhood trauma, well, they're far more likely to develop psychosis than not. We should be seeing them. So I think it is, if the idea and the whole ethos is that we embrace diagnostic uncertainty, that we have easy pathways into the service to reduce duration of untreated psychosis, then you just have to fight for that to be properly resourced and suck it up. That's what we do. You have to embrace the diagnostic uncertainty. Then making nuanced arguments that we'll do this and we won't do that and we won't do that, and then you tie yourself in knots. And coming back to what you're saying about an assertive outreach approach, it should be formulation driven. So this is something we did in the Birmingham services quite some time ago, in that saying that we'll take somebody on, they meet diagnostic criteria for psychosis, we'll take somebody on. The multidisciplinary team formulation meeting needs to happen within the first 6 weeks, if not sooner. And at that point, how you're going to manage, the approach, how with the patient, what are their primary targets, including whether we need to adopt an assertive outreach approach with this person, or whether we need to be, they are able to, taking more traditional, so not sort of chasing people around the city if they don't need to be chased. I'm being flippant here, but there's that assertive outreach approach, which is entirely appropriate and needed for some people with psychosis, is not needed for everyone, and it should be formulation driven, particularly when we've got high levels of trauma. So we need to be going in with eyes open on what we're doing.
I think that is a very good advice, Rachel. Like we say in our precision medicine stuff, there's no one size fits all. There's no average patient, So yeah, I think the formulation-based approach makes absolute sense. Very often there's also this argument that once the EI service takes on a person, they will keep the person on for 3 years or 2 years. But Joe Smith, in one of this crucial article guidelines, suggests that exactly what you're saying. It should be formulation driven. Maybe this approach will not work for this person, in which case we need to kind of tailor this service or tailor the treatment according to the individual patient's need, and that makes sense. Okay, thanks a lot for that. I shall go on to the next. I think we have another 9 minutes, if I'm right. So, will first episode manic psychosis be excluded from the antidepressant trial?
Sorry?
So will first episode manic psychosis be excluded from the antidepressant trial? So that's the
Yeah. I didn't want to go through the whole of the trial details, but yeah, we would exclude people who have had a previous episode of mania, somebody that you wouldn't want to describe an antidepressant, and a few other exclusions. But generally, because it's a prevention, we're trying to see whether this outside of those people who've had a manic episode, it could be a potential adjunctive medication. And to talk through the previous point on side effects, we have within the study really robust measures of side effects and tolerance within the trial, so we can understand whether this is is something that patients would want to tolerate, and we know what potential side effects are. Anecdotally, we know that SSRIs are relatively have relatively few side effects, and we're using such a low dose that we don't need to worry so much about dose tapering.
I think there are a few questions which are kind of automatically going up. Is there enough emphasis around recovery and recovery treatment or interventions? It seems like we have lost some of this emphasis within our service professions in Scotland. I don't know if you can answer that question.
Well, I can't answer about the Scotland bit, but I think that it's a constant battle to make sure that you have recovery in your mind, and what we mean by recovery, because that differs for each individual. But it's an ethos within a service, and it's something that takes work to make sure, particularly when staff are hard pressed, there's shortages, and you feel like you're not doing your best, that we have to keep recovery at the forefront of everything we do, and that's the point, isn't it? That's the point of what we do. So it's around service managers, commissioners, consultants, leaders within a team, to make sure that we hold that recovery model in our minds, and bring the team on board with us to make sure it stays part and parcel of the thinking within a service.
I have another question from Matthew Beatty. Is lack of insight protective of shame or stigma and depression? Interesting.
Well, I think it's an interesting. It's not so much that. Firstly, insight is not just one dimension. So we might think of insight if you think of Tony David's work. Insight is just literally the ability to recognise that I'm not well, and that can be the same for any physical or mental health disorder. The ability to accurately label my own symptoms as symptoms, so knowing my voice as a voice, and then being help seeking, wanting to help have and receive care. So insight is multidimensional, and we know also that insight is rarely completely lost. So some of the work did years ago, and again, Tony David, patients rarely lose insight completely, but that bit of insight that is there is often linked to these negative illness appraisals. So it's not so much insight; it's what that insight means to the individual, in terms of self-stigma, shame, and loss, and that's where the risk comes. So all of the societal prejudice that we have, against severe mental illness, people have against themselves sometimes when they experience psychosis, and that turns inward. So again, it's up for it's for the early intervention services, and families and carers and everybody to try and address that, and to address the potential of hopelessness and shame and stigma, because it turns and it can be dangerous, and it impacts recovery. Sorry, went on for a bit of a tangent there.
I think I'll ask one more question and we'll leave it there. I have 4 minutes, it says. I suspect the whole thing will shut down at 4 minutes. Is there a pathway or guidance to help reduce the DUP period?
Well, we know that a couple of things work. So early intervention services, arms services, and that kind of community, outreach. Interesting from the National Eden work, we found that the most significant delays for duration of untreated psychosis were in tortuous pathways into care once people had entered mental health services. So yes, people help seek, they ask for help. There's a delay in that, and then there's another delay within services. So the most important thing, and we can think about guidelines, and happy to send it, is what happens when somebody asks for help or is seen by a home treatment as a crisis service, or a CMHT. There should be a seamless entry to getting treatment and EI care, and not the nuanced delays about, is it primary psychosis? Is it not primary psychosis? Is it affective? Is it not? So patients getting lost within pathways. So the pathway needs to be seamless into EI, because we know that there were significant delays within mental health services when that's not sorted out. Hope that makes sense.
Yeah, no, absolutely. I'm just aware of the time. We have quite a lot of questions there, Rachel. So I'm hoping that we can send these questions to you, and some of these questions you could kind of answer by and we can kind of post it back on our website probably. Finally, so I'm wondering if we can kind of bring this to a close. To keep informed on the work of the EIP National Programme, follow us on Twitter, visit our website, or request to be added on our national network mailing list. A newsletter with latest updates from the programme is made available monthly via these channels. Once again, I would like to thank Rachel for coming in, for accepting the invitation and delivering a fantastic lecture. And I would also like to thank the audience for their participation and the fantastic questions. Thanks a lot.
Thanks for the invite. Appreciate it.